Perfect. I just want to go through some of the anatomy. I think that, we focus a lot on unusual diseases and so on, but sometimes I think we skip over some of the basics. So let's get started with just some normal cases and anatomy. So we'll start with the midline sagittal view. And the midline sagittal view, I think, teaches us a lot of anatomy that you can't learn from CT, at least the way it's traditionally displayed on CT imaging. So I don't know if anybody wants to join in and tell me what structure is this right here?
Yeah, mammillary body.
Perfect. Mammillary body. And this, what is this other bright area here that sort of usually see along with the mammillary body? Well, let's skip over to this. What's this structure here?
Oh, the corpus callosum.
Perfect. Okay, and the corpus callosum, we think of it in sections: the splenium, the body, the genu, and the rostrum. Now, there's another structure here sort of reminiscent of the corpus callosum. And what is that?
The fornix.
Fornix, perfect. And then this, so that makes this the anterior commissure. So the fornix will bring us to the anterior commissure. Then there's a line that runs along here. This is in the front of the third ventricle. It's called the lamina terminalis. That brings us to the optic chiasm. And then we have the infundibulum here. And a lot of times on high resolution imaging, you can see there's a little recess, a little V-shaped structure here and here. So this is cleverly, or not so cleverly named, chiasmatic recess and the infundibular recess. I like those because they make sense. So now that we have the anterior commissure, then this structure right here, this little C-shaped structure, it's like a comma that sits on top of the quadrigeminal plate. This is the posterior commissure. That brings us to the midbrain, the belly of the pons, or the basis pontis, the pontine tegmentum, the medulla. And this is the transition here from the medulla to the cervical cord at the craniocervical junction. The veins in this location are going to be in the midline, the internal cerebral veins, which will come up and become the vein of Galen here, and then dive down to become the straight sinus. We'll come back to that a little bit. In terms of cerebellum, I don't think you need to know all the lobules of the cerebellum. You may want to know the vermis of the cerebellum and so on. But usually some of the detailed anatomy, I would rather you learn some vascular anatomy before you learn like all your sulcal anatomy and so on. Now, I just want to show you some examples of some high resolution imaging that will go over some of the cranial nerves. So what would this cranial nerve be right here? It sort of comes out, I didn't show it really that well here, but it comes out of the interpeduncular cistern and sort of comes across like a V into the top. You can see here the cavernous sinus.
Oculomotor.
Yeah, exactly. That's the third nerve. So again, these, they're numbered in order, which makes it a lot easier. So the first one, we have the olfactory, then optic, and then this is 3. So this is the third cranial nerve, which comes into the cavernous sinus. And this is what it looks like on the coronal imaging. It's gonna live in this area, and it actually lives. I didn't show it that well here, but if you do vascular imaging, the third nerve lives between the posterior cerebral artery and the superior cerebellar artery, which is why some people believe the third nerve is frequently associated with involvement with posterior communicating artery aneurysms because of its proximity to the posterior communicating artery. But again, it lives in the cistern where I think it's at risk from that compression. This cranial nerve, what's this one? Anybody?
Trigeminal.
Trigeminal. That's the largest. So this is the largest of the cranial nerves, the one that's easiest to see. You notice I skipped over 4 because it's so small. Yeah, and it has an unusual course that you really almost never see it. Honestly, I can't say I've ever really seen the 4th cranial nerve. So this brings us to the 5th cranial nerve, which comes to Meckel's cave. And in Meckel's cave, the nerve is going to give off a branch, which is going to go through the foramen ovale, which you should know on CT, be able to find on CT. And that branch we have the third division of the trigeminal nerve. The second division is going to come through foramen magnum, and the first division is going to come through the superior orbital fissure. But only the first and second divisions live in the cavernous sinus. The third division comes off just at Meckel's cave. And so there's some nice anatomy here. This is the root entry zone. And when you do scans looking for things like tic douloureux or atypical tic douloureux and so on, you're looking for vascular loops or some lesion in that location. It doesn't have to be vascular. It could be a tumor, could be a DVA, it could be an MS lesion, could be an infarct. It's not really, the symptom of tic douloureux symptom complex is not really linked to a specific pathology, but it tends to be linked to an anatomic location. And then if you have a tumor that involves the Meckel's cave and the cisternal portion of the nerve, you want to be thinking about a nerve sheath tumor involving the fifth cranial nerve. Now, this is a steady state precession or cyst scan, depending on your scanner. And just a nice depiction of some of the anatomy here. We have the seventh and eighth nerves here. And then there's a nerve which comes off at the pontomedullary junction and goes sort of straight forward. And see, it comes to the dura here. Anybody know what that nerve is? You can sort of get it from the numbering, right? So this would be the sixth cranial nerve, right? So we went from 5, 7, 8. This is the sixth. And the sixth has an unusual course as it comes forward. And here it's going to join into a dural sleeve that you can't really image, at least not with the technique we're using. And it goes through what's called the Durella's canal. So we saw the third cranial nerve came into the cavernous sinus from the top, and the sixth cranial nerve is going to sort of work its way up along the clivus to join the cavernous sinus. We can go through cavernous sinus anatomy another time. That's actually a little more complicated, but again, I want you to be able to at least find the region of these cranial nerves, because oftentimes patients are referred with a specific cranial nerve abnormality. This is the imaging you're probably used to seeing. This sort of scan in patients who have a suspected or proven vestibular schwannoma. And here you can see the seventh and eighth nerves as they live in the internal auditory canal. Some other anatomy that you can see here, this is going to be the vestibule, and this is the cochlea. So the cochlea is in front. I think of C comes before V. So the cochlea is here, in the semicircular canals are posterior. This is probably the superior semicircular canal that you see here. So again, nice anatomy on these thin section images. Notice there's a vascular loop in here. This is usually the loop of the anterior inferior cerebellar artery. And don't get too caught up in that. Even I mentioned vascular loops around the fifth cranial nerve root entry zone can cause symptoms. These vascular loops inside of the internal auditory canal are not thought to be significant, and I would never attribute a patient who had like hearing loss or the like to be as a result of a vascular loop there. So again, we make a fuss about them in one place and not in another. Some last venous anatomy. Venous anatomy, I think you really should understand a little bit about the deep and superficial venous system. The superficial venous system, the largest component, of course, is the superior sagittal sinus. Then you have its little, sort of sibling here. This is the inferior sagittal sinus. And these together will define the width of the falx. So the falx is wider back here than it is up here. This runs along the free edge of the falx. I mentioned the internal cerebral veins, which come in to form the vein of Galen. Not showing it that well here, but I'm shown on this nice Netter drawing, coming from the side, so not seen on a midline sagittal view because they're off to the side and they wrap around the midbrain. This is going to be the paired basal vein of Rosenthal, or basal veins of Rosenthal. And these will join with the inferior sagittal sinus and the paired internal cerebral veins to form the vein of Galen, which then goes into the straight sinus and torcula and so on. So again, I would focus on this midline anatomy. You should be pretty comfortable with all of those structures that I pointed out to you: midbrain, quadrigeminal plate, mammillary body, chiasm, and so on, be able to recognize them on the scan, and then spend a little time looking at venous anatomy, particularly want to be able to identify at least the large venous structures. Now, I'm going to just show you some sort of typical vascular anatomy. These vascular territories you need to be able to recognize, because this will come up when you see lesions and you're not sure whether you have a tumor or an infarct. One of the basic tenets is that if it doesn't conform to a vascular territory, you usually will favor something else, like let's say you're in the temporal lobe and it involves the medial and lateral aspects of the temporal lobe. Well, in that case, you're probably not dealing with an infarct because those are two different territories, and you want to be thinking more like herpes encephalitis or tumor glioblastoma, something like that. So here, what vascular territory is this that hugs the midline and along the falx?
Anterior cerebral.
This is the ACA territory, right? And the ACA territory can be incomplete because you have this cross connections between the sides. So you may only have, and you might be a branch occlusion, you're on at night and it's a stroke alert, and you see part of the ACA territory is involved, but that's possible because you can, you might have a branch occlusion and may not be the trunk. But if the trunk is occluded, the proximal A2 division is occluded, then of course you might see the whole territory involved. This territory, of course, is the middle cerebral artery territory. You notice it involves the basal ganglia, which tells you that you have a proximal occlusion in the MCA because those branches come off the M1, basically the first division of the middle cerebral artery. This is a subacute infarct because you see there's swelling, there's loss of the cortical sulci here. So you really shouldn't be seeing this in the ER if the word is getting out to come to get your care for the acute brain attack right away. When you see this degree of swelling and this well-defined infarct, this is a patient who's not eligible for intervention. And again, this stroke probably occurred a day before or so. But this is a nice depiction of the entire MCA territory. And again, this helps us to identify this is the anterior cerebral territory, which is spared, and this is the posterior cerebral territory, which is spared. And this line between the two territories is called the watershed zone. Not hard to understand that, sort of thinking about, in terms of, I guess, geology, but the idea that we're in between these two vascular territories in the watershed, and you will occasionally see infarcts in that distribution. This is a very specific infarct and involves the posterior limb of the internal capsule and may involve a portion of the thalamus. And if you see this after, let's say the patient had a ipsilateral posterior communicating artery aneurysm operated on, and the patient has now, in the postoperative phase, has weakness, which of course is going to be on the other side. So this is left side, they would have right side weakness. What vessel is involved here? Any takers on that? So this is the anterior choroidal artery territory. So what happens is, in that particular circumstance, is that the clip, if they're not, for whatever the vagaries of visualization and the anatomy and the size of the aneurysm and so on, if the clip extends back and they mistakenly clip the anterior choroidal artery, it gives you this pure anterior choroidal artery infarct. In your practice, you're not going to see too many of these infarcts with the exception of the surgeries. However, if you have a carotid occlusion, you can occasionally have an ipsilateral anterior choroidal artery infarct, meaning that the cross flow from the opposite side through the circular Willis may allow you to not see any cortical infarctions anywhere else, but you may have loss of the anterior choroidal. So again, recognize that particular pattern of disease, anterior choroidal infarct. This patient has a finding that you're going to, patient, let's say there's a stroke alert and the patient has right-sided weakness. What's the finding on this scan?
Hyperdense MCS.
Exactly. Now, don't get too caught up with that. And I just saw a case today that looks a lot like this, but it was a calcification in the wall. So the proximal carotids, as you know, can frequently have calcification. It's not really in the atherosclerotic disease. It's probably in the adventitia or intima, but it's not really the same as the way we think about calcifications in the internal carotid. But it's very common. You see that with aging. And so you want to make sure you correlate this with the clinical symptoms. So obviously this is on the left side. If the patient has left-sided weakness, then you're probably looking at calcium. So again, don't ever read these subtle findings of infarct without the clinical history. And if you don't have it, you should get it. How about this patient? Has new leg weakness. Which side do you think they're weak on? You guys
The left
should,
side?
if you're taking call, you should be able to recognize these findings.
The left side?
Exactly, right? And what's the abnormality called?
So you lose the great white differentiation in like the right insula?
Right, this is called the insular ribbon sign or loss of the insular ribbon. So this is the insular ribbon. So there's a little bit of cortex that follows along. So as you come across the sylvian fissure, you should have a little area of relatively high attenuation before you get to the lower attenuation of the white matter. If you look carefully, here's cortex, here's white matter, here's cortex, here's white matter. Cortex, here's white matter. If you look here, as you come across the sylvian fissure, it looks the same all the way across here. So again, it's like, if you want to think of it like landing on a beach, this is like a little island, Caribbean island, where you come up on the beach. This is like the cliffs of Dover, right? You bump into this cortex. So again, this is the insular ribbon sign, and it's a pretty good sign. You should be looking for this. The other finding, which is a little more subtle, is blurring of the basal ganglia. See the basal ganglia here, lentiform nucleus, lateral border of the putamen, globus pallidus here. It's kind of vague looking here. So this doesn't look like much, but this is all you're going to get in the acute stroke patient. And you should be able to recognize these findings because these are all factor in the aspect scoring, the Alberta scoring of infarct, which some believe has some implication in terms of who should and should not get intervention. Not everybody, but you should at least be aware of the aspect scoring. So again, insular ribbon sign. What's this vascular territory? So we're at the level of the cerebellum, sort of low, relatively low down. We're at the medulla.
Superior cerebellar artery?
Yeah, it's hard. I'm only giving you this one slice, but if you're at the medulla, this is probably the posterior inferior cerebellar artery territory here. Actually, the next case is a superior cerebellar artery territory. This respects the midline here. They don't always. You can have pica that actually goes across. Sometimes they supply both hemispheres, but usually they're ipsilateral. And if you think about it, if you were to take your hands as if you're holding like a baseball with one hand on top of the baseball and one hand on the bottom of the baseball, that's how the pica and the superior cerebellar artery come around the cerebellum. And they don't supply the anterior middle peduncle, but this hemispheric cortical involvement is very typical with SCA and PCA, pica territory infarcts. This patient has an infarct involving the bilateral thalami. And what vascular territory would that be?
Artery percheron?
Artery percheron, right? Or you could just say top of the basilar. Sometimes you can have an embolus that breaks up at the top of the basilar. It will give you bilateral thalamic involvement, but excellent. Yeah, but usually if you're in a quiz or a case review, you probably want to say percheron, but I don't know. I think you can have it with just a typical PCA or a basilar infarction. How about this is a young patient is found unconscious in a car, has to be resuscitated. What's the abnormality here? This is a diffusion scan. It's kind of a tough one, but this is all abnormal. And this, these cases are important to be aware of because I think some people think neuro is easy because the left side looks like the right side, unlike the liver, and the spleen. But but a lot of times you have bilateral disease. So this patient has bilateral disease of all of the basal ganglia, including the, thalamus, head of the caudate. And this is anoxia. This is sometimes you'll see this in anoxia, that patients, because of the increased metabolic demand of the basal ganglia, that they can be selectively affected. Even though the whole brain has experienced the insult, it is more evident in some parts of the brain than the other. And those areas usually are the basal ganglia, the hippocampus, and the gray-white junction of the cerebellum.
Is that what you
And
would
what's this
consider?
pattern of infarction?
Watershed.
Watershed, exactly. And so the lesion here probably is, this patient probably has a carotid occlusion or high-grade stenosis on this side. And maybe on top of that, they had a cardiac arrhythmia and they decreased their perfusion pressure. And so the watershed area experienced diminished blood flow. In fact, sufficiently low that we have an insult to the white matter and the cortex. So the fact that it goes through the white matter and the cortex is very favorable for a watershed infarction. Now, if you have infarcts in the cortex, here, or white matter infarct, or I'm sorry, gray matter infarcts here or here, it could be watershed, but sometimes you're dealing with multiple emboli. So I wouldn't dig in too deeply. But when you get this reflection of, like, a lot of times it has almost like a gentle C shape where it goes through the cortex, through the white matter watershed to the cortex on the other side, you can be pretty sure that there is some hypoperfusion insult to that hemisphere. Some people, at least when I was a fellow, they used to call these top of the hotel infarcts. And I think it referred to European plumbing, where if you're on the third floor of like a French, hotel, and someone takes a shower on the first floor, the water in your shower drops down. So you think about it the same way. So if you have marginal perfusion, and then you have some worsening of the perfusion pressure, whether it's from, like, it shouldn't be a tight collar, but something, that impairs the flow through an already impaired blood vessel, you may have an insult that occurs at the margin of perfusion. And that's pretty much all I had for you today. So I try to keep these short so people don't shy away because they don't want to feel bad leaving early. But I hope you find that helpful, and I'll try to do a few more of these basic things. If you think that's too basic for you, then please let me know. But I think some people were asking for some going back to beginnings. Any questions for me? Any comments?
Thank you. But basic is what I need.
Yeah, I echo that. Thank you.
Okay. Well, I think it's always good to go back, and I think that just to be not too philosophic about it, I think one of the problems with medical education in general is that there's a tendency to focus on a lot of the exotic things. And I think there's an assumption that if you know all the exotic stuff, that you will know all the basic stuff. But I think in terms of, everyone learns differently, but I tend to learn better when I think of it like a Christmas tree and the ornaments. Like, if I can build a framework of understanding and then I can hang stuff on it, I think I can make more sense out of things. So I don't know, I come to medicine like thinking more like an engineer maybe than a biologist, where like some people just remember everything, which I can't. I have to kind of have a theory why I should remember that. So again, I really urge you to spend a little time on these rotations to learn some of that anatomy. Don't get too caught up in any one part of it. You're better off knowing, sort of basic venous anatomy, basic arterial anatomy, basic, hemispheres of the brain, than to really go deeply into any one of them. And then as time goes on, then you can learn all the, the branch arteries, the odd arteries in the brain. I mean, that's fine, but that's later in your career. At this point in time, you want to know a little bit about a lot, and before you get to the point where you know a lot about a little. Well, thanks very much. Hope you all have a good evening.
Thank you so much.
Thank you.
We appreciate your time.
Pleasure.